I'm going to take a topic on general anesthesia. So, first of all, one of you confirm me that you are listening me properly, so we can start. Okay, here is the reply. Yes, sir. Okay. So, general anesthesia, you might hear the term anesthesia, that person have a procedure and under GA. And there is another term that we can use that is related to anesthesia is the local anesthesia, local anesthetic, right? So our main focus today in today's lecture is the general anesthesia, right? So first of all, one of the term that we use is the anesthesia is a reversible condition, is a reversible condition of comfort and physiological stability in a patient before, during and after performance of a procedure. So it should be reversible condition because in anesthesia we are going to inhibit or suppress the autonomic reflexes, so we can stable the cardiovascular status especially. So okay, before continuing, I just want to clear one point because one of the student has marked remarks that lecture is started at 10:35 because we for 3 or 5 minutes we just wait for the gathering of the student, right? So when you were gathered like 30 students, so then I have started. Otherwise I was here and just waiting for gathering of these students, right? So this is one of the reason that I have started the lecture at 10:35. Now it's clear. So in general anesthesia for a surgical procedure to render the patient unaware and unresponsive to the painful stimuli. When we apply, we use the knife for a surgical procedure, we are going to apply the painful stimulus. And you know what happens if there is painful stimulus? It will stimulate the autonomic reflexes, right? Autonomic reflexes, especially activity of sympathetic nervous system is going to be activated more powerfully. So what will happen? What will happen? It will lead to disturb cardiovascular status especially, right? And during surgical stress, it's going to stimulate adrenal gland as well, right, in response to painful stimulus. So that is why the purpose of general anesthesia for surgical procedure to render the patient unaware, unresponsive to the painful stimuli, to avoid the stimulation of autonomic reflexes. And what will happen that we have discussed in response to stimulated reflexes. Now this surgical stress, what will happen? It will evoke HPA axis, hypothalamus pituitary adrenal gland axis, and sympathetic system that already we have discussed. Tissue damage during surgery, because when we are going to cut, right, so basically we are going to damage the tissue. So tissue damage during surgery induces coagulation factors and activates platelets, leading to hypercoagulability of blood. So the purpose of anesthesia to decrease the components of surgical stress response, like evoking of hypothalamus pituitary axis, stimulation of sympathetic nervous system, and stimulation of coagulation factors, right? So anesthesia decreases the components of surgical stress response. Anesthetics are associated with the same thing that already we have discussed in the beginning, the same concept. So anesthetics are associated with decrease in systemic blood pressure, decreases myocardial depression, and decreases direct vasodilatation, blunting of baroreceptor control, and decrease central sympathetic tone, right? Because these are the baroreceptors. When there is a change or variation in the blood pressure, so baroreceptors, they are stimulated and controlling the blood pressure response due to sympathetic activity. So we are going to blunt these receptors so we can control the sympathetic activity. The hallmark of anesthesia, there are three important characteristic features. And when we say the term, there is a term that is also used that is called the balance anesthesia. And the balance anesthesia, why we use this term, balance anesthesia? Anesthesia produced by a mixture of drugs, often including both inhaled and intravenous agents. The ideal anesthetic agent should have these three important characteristic features. It should be able to produce analgesia, it should be able to produce muscle relaxation, and it should be able to produce unconsciousness or amnesia. And one interesting point that I want to share with you is still we have no single agent as far as the general anesthesia or general anesthetics are concerned, that still there is no single agent, anesthetic agent available that is not capable to produce all these three characteristic features, right? So that is why we'll have to use the combination of drugs. So combination of drugs means it could be intravenous, it could be inhaled anesthetic agents, right? So this point is important. So ideal anesthetic agent should be able to produce these three important characteristic features: unconsciousness, analgesia, and muscle relaxation. Now, this is another term, pre-anesthetic medication, and there is a role of pre-anesthetic medication. And when we prepare our patient one day before the surgery, so we use pre-anesthetic medications. And what is the importance of using pre-anesthetic medication? It is the use of drugs prior to anesthesia to make it more safe and pleasant. Number one, because I have an operation tomorrow. Definitely, I am in very anxietic state or depressive state. To relieve anxiety, we can use a group that is called benzodiazepine group to relieve the anxiety and to prevent allergic reaction that can occur in patient, right? So antihistaminics generally we use to prevent allergic reactions, to prevent nausea and vomiting, because in some patient, when they think about the surgical procedure, so they become nauseated, and because when we prepare the patient in OT, right, so nausea and vomiting can be stimulated, right? To avoid this problem, to prevent nausea and vomiting, we can use antiemetics. To provide analgesia, generally we use which group? Opioids group that we can use to provide analgesia. And to prevent, this is very important point that you must remember, to prevent bradycardia and secretion, we use atropine, that is the anti-muscarinic agent. And we can also use the term anticholinergic. So which anticholinergic we can use to prevent bradycardia, especially during the procedure. Patient may be bradycardic, right? So in that situation, we can use atropine. So it will prevent bradycardia. So this point is important. You must remember this point that is related to atropine. Now, stages of anesthesia. Stage 1, that is the analgesic state. That means patient is pain-free, but is still conscious, right? Because in stage 1, patient is not unconscious, but it is pain-free, calm, and quiet patient, right? Stage 2, that is also called the disinhibition state. Stage 1, the analgesic state. Now, the stage 2 is the disinhibition state, in which, you know what happens? The patient appears to be delirious and excited. Amnesia occurs, reflexes are enhanced, and respiration is typically irregular. Retching and incontinence may occur. Right? But one important point I want to share with you, the current anesthetic agents, by using current anesthetic agent, this current anesthetic agent quickly enter from stage 1 to directly enter into stage 3. It avoided or bypasses the stage 2. So fortunately, in the current status, we don't have stage 2. That is dangerous, right? So because we have the rapid acting anesthetic agent that directly enter from stage 1 into stage 3. That is why how we can check it, because when I was doing my house job and doing my ward in the surgery department, so we have attended OTs multiple times. So our senior just to teach us, okay, when we induce anesthesia by using intravenous anesthetic agent, they just administer intravenous anesthetic agent and just ask the patient, okay, why you have come over here? I have come for the procedure. Okay, what is your name? And they just reply, my name is, and become unconscious. So this is how anesthetic agent acts, and rapidly acting. So even we start injecting the drug anesthetic agent, intravenous anesthetic agent, and within second the patient enter into stage 3. So it bypasses the stage 2, which is a dangerous, right? So this is important, right? We have to control the anesthetic quantity, anesthetic concentration, because if we are not going to our anesthesiologist, so why it is labeled as or considered one of the specialist field, and most of the surgeons, they have specific or they're willing to work with specific anesthesiologists. Why? Because they have expert skill to control the anesthetic amount. So decreased chances of post-anesthetic complication that may be related to, that may be correlate with the surgeon. So that is why they prefer to work with a perfect or expert anesthesiologist, right? Why? Because they control the concentration, so we can avoid the medullary paralysis, respiratory and vasomotor control that can be ceases, right? So that can occur. So this is one of the skillful field working as an anesthesiologist. Clear? So there are 4 stages. Stage 1 that you remember, analgesic state, and stage 3, which is we are required to produce the procedure, that is the surgical anesthesia. So what is the, because we are discussing pharmacology, so how it's going to depress the reflexes or produces unconsciousness through which mechanism, right? So because when we are going to suppress the neuronal activity, so one of the possible mechanism, what we have done in the upcoming lecture, we will discuss one of the major group is the benzodiazepine group, and a very famous drug that is called diazepam is one of the famous drug that related to this group, benzodiazepine group. Midazolam, so this is another drug that is being used. So how it's going to produce the activity, how it's going to suppress the neuronal activity, right? By GABA mediated action, gamma aminobutyric acid, which is the inhibitory neurotransmitter, and its activity is potentiated by halogen. This is one of the anesthetic agent, propofol, etomidate, and another possible action is the NMDA mediated inhibition of the receptor and methyl D-aspartate receptors, right? So that is inhibited by ketamine. This is another anesthetic agent, right? And this is one of the intravenous anesthetic agent. So that we will discuss later on. Now, this is the explanation. There are two types of anesthetic agents: inhalation anesthetic agents and intravenous anesthetic agent, right? And generally, you know, what we have discussed, when we say balance anesthesia, that means because there is no single agent up till now is available to produce balance anesthesia. For achieving balance anesthesia, we are going to use both inhalational anesthetic agent as well as intravenous anesthetic agent. So we use the combination, right? And how? Because inhalational anesthetic agent that we use for the maintenance of anesthesia, and for the induction, right, we use intravenous anesthetic agent. For the induction of anesthesia or for producing anesthesia, we use intravenous anesthetic agent. And when we use inhalational anesthetic agent during the procedure, when there is a need to maintain the anesthesia, we can use inhalational anesthetic agent, right? So inhale, and this is the one of the experience that I can share with you. There was a procedure during my house job period. So there was a procedure related to appendicectomy, and due to some complication, right? Because anesthesiologists they know, okay, this procedure is required. Suppose 15 minutes or 20 minutes procedure. So they produce the anesthesia according to that duration, right? But due to some reason, the procedure become prolonged, right, due to complication. And the surgeon told anesthesiologist patient is lighting and reflexes are coming back. So because how they come to know that patient become light term is used when the reflexes are coming back, like increasing blood pressure that we can check on the monitor, right? So that means the activity patient is going to recover, start recovering. That is the term that we use. The patient is light, patient is okay. So that surgeon requested the anesthesiologist, I just need more 5 minutes. Please give to just try to maintain this anesthesia for just 5 minutes. Okay, sir. So they use in that situation inhalational anesthetic agent just to maintain or just to prolong the anesthesia if there is duration is increased due to some complication and due to some other reason, right? So inhalation anesthetics, advantage of controlling the depth of anesthesia. Metabolism is very minimal, and it is going to be straight out by exhalation, right? So these are the advantages of inhalation anesthetics. Now, inhalational anesthetics, we classify into two major groups: non-halogenated gases, and one of the important non-halogenated agent that is basically gas is the nitrous oxide that is being used in the anesthesia, and that you must remember. And halogenated hydrocarbons, this is another group related to inhalation anesthetics, in which we have halogen, infloran, isofloran, desfloran, sevofloran, and methoxyfloran is not being used, or the use this compound has been withdrawn. Their nephrotoxicity. One important point: we have to monitor the kidney status, right? You know, before performing surgery or any procedure, there is a protocol. We just do the baselines, right? Just do the baseline, like the blood CBC. We are going to check the sugar level. We are going to check the urea, creatinine, or electrolytes, to check the kidney status, right? We advise the X-ray chest. So these are the baseline investigations that always recommended before any procedure, right? So to avoid the complication and to select the appropriate anesthetic agent, right? Because if a patient having neurological problem, so we'll have to be very, very conscious to select a drug that is not going to disturb the neuronal activity, right? If a patient having liver disease, or if a patient having kidney disease. So by advising, by recommending these baseline investigation, we come to know, okay, patient is either patient have any comorbidity or not, right? If a patient having some diseases, so we can select the agent accordingly. So methoxyfluorine has been withdrawn because of severe nephrotoxicity. The point is the halogenated hydrocarbons, right? So they have a fluorine compound basically. So this fluorine component is toxic to kidney tissues, right? So we'll have to monitor. We will have to be very, very careful, right? Not to exceed the dose, to avoid the disturbance in the kidney function. But methoxyfluorine mildly produces nephrotoxicity, so that is why its use has been obsolete now. The important characteristics of inhalational anesthetics which govern the anesthesia are, this is important slide from the exam point of view, right? So the important characteristics are those: number one, solubility in the blood. And please focus on this slide, because some of the points, if this concept is clear, so you will be able to understand the different conceptual points that we can discuss in the upcoming slides. Number one, solubility in the blood. That is the ratio between blood and gas partition coefficient. Number two, solubility in the fat. That is the ratio between oil and gas partition coefficient, right? So solubility in the blood and solubility in the fat, right? Now, one by one. Blood gas partition coefficient. It is a measure of solubility in the blood, and it determines the rate of induction and recovery of inhalational anesthetics, right? So what is the important measurement that determines the rate of induction and recovery of inhalation anesthetic agent? Blood gas partition, blood gas partition coefficient, right? Now, lower the blood gas partition coefficient, faster the induction and recovery. Like nitrous oxide is the example. Higher the blood gas partition coefficient, slower induction and recovery. An example is halogen. We can say the induction and recovery is inversely proportional to blood gas partition coefficient, right? Because if the blood gas partition coefficient is lower, faster the induction and recovery. And if the blood gas partition coefficient is higher, slower induction and recovery. Please don't confuse, because in the subsequent slide we have a picture from the Canton book that it will further clear this concept. Okay, because you know, inhalational anesthetic agent, they are moving from in which the importance of diffusion phenomena is important. The molecules of inhalational anesthetic agents, they are moving from higher concentration to lower concentration. Okay, so when we apply a mask or and start induction, so because when we are producing gases or inhalational agent that is in higher concentration, and at that time when we start administering the anesthetic agent, at that level the concentration is lower in the lungs. When we start administering the drug, the amount of drug from higher concentration, that is the outside source, administering or entering into the lung, and from the lungs, right, it dissolves. If it's take time to dissolve in the blood capillaries, so that is called the high blood partition coefficient, because first it's going to dissolve in the blood, then molecules will move further into the brain tissues, right? But if molecules, they are not going to dissolve, they just move quickly, that they will enter into the alveoli, and from alveoli enter into the blood capillaries, and from blood capillaries it will move quickly into the brain tissues, and it will induce the anesthesia. Okay, when we stop the administration, right, we stop with suppose we stop further administration of anesthetic agent. Now the reverse phenomena will occur. Now before stopping, when we stop the further administration of anesthetic agent, now focus, now the maximum concentration has been achieved in the brain tissues. Now the highest concentration in the brain, and because we have stopped further administering, now what will happen? Reverse phenomena will start. From the molecule will start moving from high concentration to lower concentration. Now the molecule will move from blood to into the alveoli, and from alveoli it will be exhale out, right? So this is how we can achieve the recovery, right? So but if molecule before moving it dissolve in the blood, so it will take time. But if the molecule is not going to dissolve, it will just move, so it will induce rapid induction. So that is why if the solubility is higher, the induction and recovery is slower. If the solubility is lower, the faster the induction and recovery. Clear? Now this is the nitrous oxide, and the previous slide what we have discussed related to nitrous oxide. Nitrous oxide having low blood gas partition coefficient, and it's not going to dissolve in the blood, so that is why the faster induction and recovery. So you can see the solubility is just 0.47 as compared to halogen, that is 2.3, higher solubility. right? So higher solubility, high blood gas partition coefficient, and slower the induction and recovery. And lower the blood gas partition coefficient, that means lower the solubility, rapid movement, so it's not going to waste time. That can occur during the dissolving process, right? So it will move quickly from the blood into the brain. Okay, this is another diagram, you know, blood gas partition coefficient. This is the diagram that is correlate the function of nitrous oxide. The molecule, because we are administering through airway inhalational agent, and the molecule rapidly moving from alveoli into blood, then into brain. There is no dissolving process, right? But in case of this halogen example, first molecules, they are going to dissolve, then it will move into the blood, then into the brain. So it will take time. So higher the solubility, slower the induction and recovery. Clear? I think now it's clear. Now oil gas partition coefficient, it is the measure of lipid solubility. You know, because the drug has to pass lipid bilayer. So if the agent or anesthetic agent has the capability to process the lipid bilayer, that is supposed to be the potent anesthetic agent. And lipid solubility, the blood gas partition coefficient correlate the induction and recovery. And oil gas partition coefficient, that shows the lipid solubility, that can easily process the lipid bilayer, so easy movement from one compartment to another compartment. So lipid solubility correlates strongly with the potency of the anesthetic agent. So higher the lipid solubility, potent anesthetic agent that would be. And the potent anesthetic agent is the halogen, because this halogen has the higher or highest lipid solubility as compared to other anesthetic agents. So don't confuse with these two terms. Again, I'm repeating, the blood gas partition coefficient correlate the induction and recovery. Movement of molecules is correlate the movement. So how it will reaches the brain rapidly, quickly, and from brain again reverse to produce recovery, the movement of molecule from brain to blood and then into the air through alveoli, right? And the oil gas partition coefficient, it is the measurement of lipid solubility of anesthetic agent that correlate the potency of the anesthetic agent. Now this is another term and that commonly used, and this is one of the important concept that is related to the exam point of view, MAC value. This is a question that is commonly asked in the OSPI in the station, because you must have a station related to general anesthesia. So this is one of the questions that is commonly asked. Okay, what do you mean by MAC value? And MAC stands for minimal alveolar concentration. So, you know, inhalational agent, lungs play a vital role, right? So minimal alveolar concentration, it is a value, it is a measure of inhalational anesthetic potency. And it is defined as the minimum alveolar anesthetic concentration or percentage of the inspired air at which 50% of patients do not respond to a surgical stimulus. What does it mean, do not respond? That means at this concentration, we are going to blunt the autonomic reflexes, right? So we can say there is another explanation, the alveolar concentration of an inhaled anesthetic that is required to prevent a response to a standardized painful stimulus in 50% of patient. Clear? So MAC values are additive and lower in presence of opioids. This is another important point, because opioids we use generally for analgesia. So this is one of the compound that suppresses the painful stimulus, right? So what you will say, if we are using opioids, so and we are using another inhaled anesthetic agent, the MAC value would be higher. High MAC value is required for achieving surgical anesthesia, or the MAC value will be lower when we add opioids. Lower, right? Because further this opioids, now the anesthetic agents, now low concentration is required, because some of the activity is covered. Thank you, correct answer. Some of the activity is covered with opioids. Now this is related to potency of the inhaled anesthetic agent, oil gas partition, right? So you can see the MAC value and oil gas partition coefficient, right? So halogen, isoflurane, sevoflurane, desflurane, nitrous oxide. So which compound? What we have mentioned: halogen, isoflurane, sevoflurane, desflurane, nitrous oxide. So out of these 2, 3, 4, 5 compounds, right? So which compound required the lower MAC value, and why? Why? Halogen, because it is more highly lipid soluble, right? So powerful, the most powerful, already we have discussed, the most powerful, the potency of the anesthetic agent is related to oil gas partition coefficient. The higher the lipid solubility, and you can see here the highest lipid solubility, halogen, then isoflurane, then sevoflurane, then desflurane, then nitrous oxide, right? The most potent is the halogen and the least potent is the nitrous oxide. So there is another explanation. We cannot use nitrous oxide as a sole agent or as a single agent to produce anesthesia. So 100%, we cannot use 100% nitrous oxide, right? So the MAC value, you can see the nitrous oxide, because the lower the lipid solubility, higher the MAC value. Clear concept? Okay. Now again, this is for the explanation. You can see an inhalation anesthetic agent, the MAC value which is required to suppress the reflexes against the painful stimulus, more than 100%, right? And because its oil gas partition coefficient is 1.4, desflurane 7.2, MAC value 2.5, in case of sevoflurane, isoflurane 1.3, halogen least MAC value 0.8, because it has the maximum lipid solubility, and oil gas partition coefficient value is 250, you can see over here. Inhalation, and now the specific agent. What are the important points that at least you must know? There are more points that you can concern with books, like you can find out some more points from the Kaizen, or either from the Kaizen or from the Lippincott. But these are the important points related to individual inhalation anesthetic agent. The important concept what we have discussed, that is very important. The concept of oil gas partition coefficient and blood gas partition coefficient, and which one is responsible to correlate which character of an inhalational anesthetic agent. Now, nitrous oxide, the non-halogenated, in the initial slides already we have discussed, and this is the single or only agent non-halogenated which is in the form of gas, safest inhalational anesthetic, wide margin of safety. But the drawback of this nitrous oxide is the weak anesthetic, but a good analgesic. And this concept, again, you can correlate why nitrous oxide is supposed to be the weak anesthetic agent, because it has the lowest oil gas partition coefficient ability, because it's the least potent, so that is why it's a weak anesthetic, but a good analgesic, right? No toxic effect on the heart, liver, and kidney. Clear? There is a question, can we correlate MAC value with blood gas partition coefficient? So in the beginning, I already told you there is no need to confuse the blood gas partition coefficient. It's correlating the movement of the molecule, right? Movement of the molecule, right? That means the blood gas partition coefficient correlating the solubility in the blood, not penetrating the lipid bilayer. Two different things. So please don't confuse. The blood gas partition coefficient is correlating the movement of molecules. So it is correlating with the induction and recovery. But the oil gas partition coefficient, it's showing the potency of the anesthetic agent. Two different things. So please don't confuse. Clear? So nitrous oxide, no toxic effect on the heart, liver, and kidney, non-irritant and non-inflammable. Because this is the general concept, if we are administering the anesthetic by inhalational route, by using bronchial tree, right? So it could be irritating, right? So this is one of the beneficial point of nitrous oxide is non-irritant and non-inflammable. And this is another drawback. Poor skeletal muscle relaxant, because in the beginning already we have discussed three important characteristic features, the hallmark of anesthesia. One is unconsciousness, amnesia, number two, analgesia, and number three, skeletal muscle relaxation. These three characteristic features are the hallmark of anesthesia. So this nitrous oxide doesn't produce skeletal muscle relaxation. So definitely if we are using nitrous oxide, we'll have to add potent anesthetic, because okay, nitrous oxide providing powerful analgesic, good analgesic property, but weak anesthetic, and at the same time the third hallmark is the skeletal muscle relaxation, which is required, that is poor with nitrous oxide. So we cannot say this nitrous oxide, we cannot label nitrous oxide is one of the ideal anesthetic agent just because of these two. Okay, question about diffusional hypoxia and megaloblastic anemia. So one important task I'm giving you, the students, right? Because, and that I will ask in the second lecture, that is on 2nd September, that is on intravenous anesthetic agent. And what is your homework? And before starting the inhalation anesthetic agent, two important discussion we are going to discuss before starting intravenous anesthetic agent. One answer that you are going to search, what do you mean by diffusional hypoxia, or why nitrous oxide is going to may produce diffusional hypoxia, or why diffusional hypoxia occur after using nitrous oxide, or can occur after using nitrous oxide. One point, and why there is a chance to produce megaloblastic anemia after using nitrous oxides. So these are the two important questions. Please note it down. And before starting intravenous anesthetic agent in the upcoming lecture, we are going to discuss these two questions, right? Just to participate your activity. Okay, so second, halogen. And what is in the previous slides, one of the important point of this halogen is a potent anesthetic, right? So from the BCQ point of view, the most potent anesthetic agent as far as the inhalation anesthetic agents are concerned are halogen, because the highest lipid solubility, and the least potent, that is the nitrous oxide. Clear? So halogen is a potent anesthetic but poor analgesic activity. So please, again I am repeating, the potency is related to lipid solubility. That means they are powerful. Three important hallmarks I am repeating again: unconsciousness, analgesia, skeletal muscle relaxation. So potent anesthetic, they are powerful, they are going to produce unconsciousness, right? So halogen is a potent anesthetic. Okay, one of the characteristic feature is fulfilled. One of the hallmark of anesthetic agent is fulfilled, because they are going to produce unconsciousness. Okay, but poor analgesic activity. The second important characteristic feature. Okay, though it's a powerful anesthetic agent, but poor analgesic activity. So definitely, if we are using halogen, we must add any agent that is supposed to be the powerful, having powerful analgesic property. And already we have discussed during anesthesia, the preferred group is not NSAID, but preferred group in during anesthesia is the opioids. Induction is pleasant, right? That means pleasant means it's definitely it's non-irritating to the airways. The important point related to this halogen, and this is one of the important point related to BCQs, related to exam, it sensitizes the heart to catecholamines, right? Epinephrine, norepinephrine, dopamine. That means halogen can induces the activity or enhances the activity of catecholamines, right? Okay, it dilates bronchus, so preferred in an asthmatics. This is one of the beneficial point of this halogen. It inhibits uterine contractions, right? So what does it mean? So can we use this halogen to avoid the premature delivery, right? This is we are correlating, because we are not using halogen to avoid the premature delivery, because when premature delivery occur, when powerful uterine contractions, rhythmic contraction is going to start, so it can expel the fetus, right? So it inhibits uterine contractions. So this correlation that we were making, but clinically we are not using halogen for this purpose, right? We have other options, like we are using Ventolin or other pharmacological agents that can be used to avoid the premature delivery by relaxing the uterine muscles. Okay, poor skeletal muscle relaxant, this halogen, because this is one of the important hallmark of ideal anesthetic agent. So one important point, power point, it's going to produce unconsciousness, but it's not going to produce analgesia properly. It's not going to produce skeletal muscle relaxation properly. So that means we must add another agent to produce balance anesthesia, right? For balance anesthesia, we are going to achieve unconsciousness, analgesia, and skeletal muscle relaxation. So these are the comparative points like nitrous oxide and halogen, which one is powerful anesthetic agent, which one is least, which one is having a good analgesic property but weak skeletal muscle relaxant property. Both nitrous oxide and halogen showing the weak skeletal muscle relaxant property. So that is why we must add a group that is going to produce the skeletal muscle relaxation. Halogen hepatitis and malignant hyperthermia can occur, right? Halogen hepatitis, that means if we use the higher dose or if we perform the surgery after a short period of time repeatedly with of producing halogen hepatitis. And malignant hyperthermia basically is occur in genetically susceptible patients, especially if we use halogen with muscle relaxant compound, that is the succinylcholine. So then there is a chance of producing malignant hyperthermia, right? So in that situation, hyperthermia, right, due to muscle spasm, due to sarcoplasmic release of calcium, right, from the L type of calcium channels. And basically this genetically susceptible patient, if there is abnormal L type channels, right, then in that situation, because not in every patient there is a chance of malignant hyperthermia, this point you must clear, right? In genetically susceptible patient in which there is abnormal L type channel, so what will happen? Abnormal release of calcium from the sarcoplasmic reticulum, right? And when this occurs, when we use halogen, when we use the combination of halogen with skeletal muscle relaxant, that is succinylcholine, then there is a chance of malignant hyperthermia. So how we can avoid this problem? By giving skeletal muscle relaxant like dantrolene. Dantrolene is the agent that can be used as antidote if this situation occurs. Inflorin, sweet and H12 order generally do not sensitize the heart to catecholamines, right? Better skeletal muscle relaxant, no hepatotoxicity and non-irritant to air passage, but one problem. What is that problem? If a patient having a history of seizure or epilepsy, right? So this inflorin may create a problem, right? Because in the EEG, it shows the spikes and abnormal wave activity. So that is why it is recommended if a patient having a history of seizure or epilepsy, you are not going to use this inflorin. And this is one of the points that is asked in the exam. This is one of the points that is asked in the exam. Can you recall the anesthetic agent that avoided in a patient having a history of seizure, right? So this is another halogen agent. Isoflurane is commonly used oxygen or nitrous oxide. It do not send to catecholamines. It pungency. This is the drawback of this isoflurane. Its pungency can irritate the respiratory system, right? So that means if a patient, especially if a patient having a history of asthma, it is better not to use isoflurane. But what is the important point of this isoflurane or important use? Preferred for neurosurgical procedures because it causes less cerebral vasodilatation. So this is one of the important points related to this isoflurane. It is preferred for neurosurgical procedures because it causes less cerebral vasodilatation, right? Because suppose we should have a clear field, right? But vasoconstricting agent, right? We are using suppose any, if more blood comes to that area, that surgical area, it is difficult to operate, right? So that area should be clean of blood, right? So preferred for neurosurgical procedures because it causes less cerebral vasodilatation, because cerebral vasodilatation, increased amount of blood will come into the brain, right? So it will be difficult for a surgeon to operate, right? Desflurane, it is delivered through a special vaporizer. It's a popular anesthetics for daycare surgery. This desflurane induction and recovery is fast. Cognitive and motor impairment are short-lived, right? But it irritates the air passages, producing cough and laryngospasm, right? Otherwise, it's a very important or commonly used inhalational anesthetic agent in daycare surgery. Now, sevoflurane, induction and recovery is fast. It is pleasant and acceptable due to lack of pungency. It doesn't cause airway irritancy, but concern about nephrotoxicity, right? So this is the reason that methoxyflurane is not being used, just because of severe nephrotoxicity. But the chances of disturbed kidney function is still, we must have in our mind if we are using halogenated compound, right? So after methoxyflurane, we must think about the sevoflurane related to disturbance in the kidney function or nephrotoxicity. Thank you so much. So you must remember two important tasks in the upcoming lecture. What do you mean by diffusional hypoxia after using nitrous oxide? And number two, why there is a chance of producing megaloblastic anemia after using nitrous oxide. You can further, I have explained about the malignant hyperthermia and malignant which inhalation anesthetic agent we can correlate with malignant hyperthermia, that is halogen. But this malignant hyperthermia, when we use halogen with skeletal muscle relaxant, succinylcholine, and especially in genetically susceptible patient. And so we can treat this problem as well, no problem, by using petroline. So if anyone is interested, it can go through with the pharmacological book, right? So thank you so much. So inshallah, the second lecture related to intravenous anesthetic agent, that will be discussed in the 2nd September. Thank you so much.